guys. I am going to be covering chapter 22 and 23 today, and I'm going to record 2 separate videos for each chapter so you guys can take a break in between, do some activities in between. So I'm going to try to keep the videos as short as possible. Chapter 22 is a little bit shorter than chapter 23. It's pretty long. So I will try to keep this one short for you guys. So I'm going to share my screen. I'll make sure I have the right one here. Okay, that should be it. All right. So chapter 22 is over hypertension. And it's a pretty short chapter. Here. Okay. Take it down here. Screen share is paused. Resume share. It's been a little bit since I've done this. All right, so we're going to talk about taking care of patients with hypertension. So real briefly, let's talk about some hypertension statistics. Okay. Hypertension is a primary risk factor for cardiovascular disease and stroke. It is the leading cause of death in the United States. Not hypertension, but death and stroke or heart disease. Okay. In 2018, nearly 500,000 deaths in the U.S. included hypertension as a primary or contributing cause. That's a lot, 500,000 deaths. Nearly half of adults in the U.S., 108 million or 45%, have hypertension defined as a systolic blood pressure greater than 130 or a diastolic greater than 80, and or taking medications for hypertension. Of those, nearly half of the American population, 1 in 4 or 24%, have their condition well controlled. And then high blood pressure costs in the United States average $131 billion to the healthcare industry each year. That is pretty staggering statistics. So this is something that we probably all know, somebody who has hypertension, or maybe even some of us have hypertension ourselves. So we're going to talk a little bit about the pathophysiology, risk factors, diet, and treatments for patients with hypertension. So let's talk about the definition of blood pressure. So normally our heart pumps and it forces the blood out and through our blood vessels to our body. And the amount of pressure that is exerted by the heart in the blood on the walls of the vessels that it's going through, the little vessels, is measured and is called blood pressure. So it's the amount of force that's exerted on the vessels within the body. So some things that determine blood pressure are cardiac output. So that's the amount of blood pumped by the heart in 1 minute. Remember, we talked about that previously. Peripheral vascular resistance. This is the ability of our vessels to stretch, okay? They don't stretch a whole lot, but they do have some elasticity to them. So they can stretch and they can also constrict depending on the needs of our body. If we need to vasodilate to get better blood flow, they can stretch. If we need to shunt blood to our critical organs, we can constrict. So we can try to control our pressure that way. But the peripheral vascular resistance is the basically when we lose our elasticity, so they become less stretchy, and anything that causes the vessels to become more narrow will increase our peripheral, I'm having a hard time saying that, peripheral vascular disease. Okay, so they kind of lose their stretchiness and they just become stiff. The vessels become stiff, and so they can become more narrow as a result of that. And then we have more pressure that is needed to actually push the blood through the vessels, because our vessels can't expand and contract like we need them to. So we have to force, a higher amount of pressure to get that blood through that stiffened vessel. So therefore, that's going to increase the blood pressure, the amount of force it's going to take to get that blood through that vessel that no longer stretches. The viscosity, so that means the thickness of the blood, can have play a role in the blood pressure. So if our blood is thick, we're going to have to push harder to push a thicker liquid versus a thinner liquid, right? And then the amount of actual circulating volume that we have within our body. So the fluid volume within our body. If we have more volume, it's going to be higher resistance, right? Because we have more, we're pushing against a greater amount of fluid, a greater amount of resistance versus less volume. It does not take as much pressure to push if there's less volume. So if we have fluid overload or fluid volume excess, that is going to lead to a higher blood pressure because it's going to take more pressure to exert and get the blood flow out. So that you'll see higher blood pressure with fluid volume excess. Okay, so that's kind of a little bit about the pathophysiology and kind of some of those factors that affect our blood pressure in a nutshell there. So I think you guys all know by now what a normal blood pressure is: less than 120 systolic and less than 80 diastolic. If we have elevated 120 to 129 and greater than 80 diastolic. And then hypertension, stage 1 and stage 2, would be these numbers right here. Okay. For those with a normal blood pressure, it's recommended that you have your blood pressure checked every 3 to 5 years. And if you're over the age of 39 or you have increased risk factors, which we'll talk a little bit about in just a minute, you need to check annually. So let's talk about types of hypertension. So there's primary hypertension, or also known as essential hypertension. And this is basically hypertension with an unknown cause. So you have hypertension, but you don't have any of the risk factors. We can't find a cause for it. That would be primary or essential hypertension. Secondary hypertension, there are known causes that we can identify, and some of those main causes are diabetes. So patients that have diabetes usually that will cause some damage to our vessels from the blood sugar being high continuously. And we can have atherosclerotic or atherosclerosis, which is a buildup of plaque or fat in your arteries. And when that happens in the arteries within the kidneys, then our kidneys help regulate our blood pressure with that RES system, that renin-angiotensin-aldosterone system, so that our kidneys play a big role in helping manage our fluid volume and our blood pressure. So then when we have decreased blood flow to our kidneys because we have plaque and fat buildup in the arteries that go to our kidneys, that's going to be a major risk factor or cause of high blood pressure. And also hypothyroidism is another cause of the secondary hypertension. Okay, but those are your mainstream causes that most people have. So our patients with hypertension, are they symptomatic? Not normally, because we really don't have symptoms until the blood pressure is really, really high. So I could live with like a 130, 140, even 150 systolic and probably never have any symptoms that are noticeable. So it is often called a silent killer, because this can go on for years and years and years. And, you know, people think, well, I'm fine. I feel fine. I have no reason to go to the doctor, or I don't get my blood pressure checked. I haven't been to the doctor in 10 years. And so they just have no idea that this is even an issue, or this is even going on, because they have no reason to seek healthcare. They're not doing, you know, preventative visits, well checks. And so they just don't know that they have hypertension, because there's really not a whole lot of side effects. It is rare, and these usually occur when the blood pressure is extremely elevated, that they can have headaches, bloody nose, shortness of breath. But again, that's not very common, and that's usually, that progresses when it gets to the point where blood pressure is really, really high. Okay. So how do we diagnose hypertension? The 2020 International Society of Hypertension of Global Hypertension Practice Guidelines. Yes, I looked this up because I was like, wait a minute, there's got to be some guidelines here. It just didn't list it in your book. It didn't go into detail. So they prefer to have it measured in both arms, preferably simultaneously. And if there's, you know, like a huge difference of greater than 20 millimeters of mercury, then that would need to be investigated. But as long as it's within 10 milligrams or millimeters of mercury, you would take the higher arm. If there was a slight difference in the two, you would use the arm that was higher. So we'll get an in-office measurement, but is one measurement enough? No, because there is a phenomenon called white coat hypertension. And you guys can Google it and look it up, and maybe you've known to see somebody with this. You know, their blood pressure is just fine, and then they get nervous about their doctor's visit, and they come in and they have a really, really high reading in the office, and then they go home and check it at home, and it's normal. So we can't go based off a singular elevated blood pressure in a physician's office. So usually they'll confirm a hypertensive reading on an outpatient basis, either by having the patient check it at home, or doing a 24-hour ambulatory blood pressure monitor, where it will take readings over an entire 24-hour period at home, where, you know, a patient's usually a little less stressed than when in the doctor's office. So those are some of the guidelines for diagnosis, along with the patient having risk factors. So risk factors would be obviously kidney and heart disease, and what current medications are on, because some medications can cause that as well. So risk factors and in and out of office confirmatory blood pressure readings is how we're going to diagnose this. So let's talk about risk factors a little bit more. So when we talk about risk factors for any disease, we are always going to have a list of non-modifiable and modifiable risk factors. So non-modifiable are risk factors that I have absolutely no control over. And then modifiable risk factors are usually related to lifestyle, and they're factors that I personally can make changes that will help lower my risk of disease. Okay, so as we get into med-surg, we're going to be talking a lot about what are your non-modifiable versus modifiable risk factors for these different disease processes. So let's talk about some non-modifiable risk factors for hypertension. This is going to be family history. I didn't choose which family I was born into or what diseases they had when I was born into it, right? So I can't control this. It's non-modifiable. But those with a family history of hypertension have twice the risk of developing it than those without a family history. And if you do have a family history of someone with hypertension, you should be screened annually. Age. So age is a risk factor. Again, I can't control how old I am. That just happens. So as we age, we can have plaque buildup in our arteries, which we talked about, the atherosclerosis earlier, and blood vessels become stiffer and less elastic. So we lose that elasticity as we age, and that increases our peripheral vascular resistance. I can't say that for some reason. So those aging changes to our vessels and our body increase the risk for hypertension. And race and ethnicity, I can't control the race or ethnicity that I was born, right? But statistically speaking, African Americans have a much higher risk of hypertension than other race ethnicity groups. So again, these are factors that cannot be controlled. I can't change those factors. Factors I can change. So modifiable risk factors. I can lose weight. Obesity plays a big part in these disease processes in the cardiovascular system. So you're going to hear over and over and over again that the modifiable risk factor for these diseases is weight control. And diet. So the recommended diet for hypertension and for any cardiac disorder is low sodium. So there is also a diet called the DASH diet, and that's recommended for those with hypertension. And it includes foods that are rich in potassium and magnesium, because we already talked about that those are our two electrolytes that work with cardiac function. And those are also shown to help control blood pressure as well. So limit foods that are high in sodium, saturated fat, which we know sodium is increasing our what? Our fluid that we retain. Where sodium goes, water goes. I know you guys haven't had fluid and electrolytes yet, but sodium draws water. So wherever water is, sodium is, and vice versa. So if we eat a lot of salt, we're going to retain water. When we retain water, we have excess fluid volume. When we have excess fluid volume, our heart has to pump harder to get past that vascular resistance to get blood to our vessels. So low salt on anybody with a cardiac condition, right? Again, the saturated fats, those fats build up on our arteries, they clog our arteries, and they make us have to push harder to get blood to where it needs to go, because either they're partially occluded or can occlude altogether, which is something we'll talk about later. So studies have shown that the DASH diet can lower blood pressure in as little as 2 weeks. So that's pretty great results. The diet also lowers LDL, remember, which we talked about was our low down lousy or our bad cholesterol. High blood pressure and high LDL cholesterol levels obviously are two major risk factors for heart disease and stroke. So this DASH diet is not only good for, you know, our hypertensive patients, but our patients with cardiovascular disease. So the average American daily intake of sodium is 3,400 milligrams. And with our patients with, which is too much, by the way, which is probably why we all have hypertension. But the recommended daily intake for a patient with hypertension should be limited to 1,500 milligrams daily. So we have to be really conscious of salt intake, and this is a really big part of helping our patients manage this disease process, because remember, before we said 1 in 4 or only 25% of these 500,000 Americans that have it, or these half of the American population that has it, is not well controlled, because probably mainly we're not controlling our modifiable risk factors, which is for Americans our diet, right? So education on this is extremely important for our patients about sodium intake. And I think a lot of Americans are just uneducated on this in general. They don't know how to read food labels. They just don't know what they don't know. And so really it's our job as healthcare providers to educate and teach them on this. Because yes, we can give them medication and we should give them medication to treat it, but we really need to give them the tools to help them help themselves with these modifiable risk factors. Regular physical activity, so walking. It doesn't have to be, you know, some huge high intensity cardiac workout for these patients, cardio workout. It can just be moderate exercise. You know, I'm walking my neighborhood, I'm walking around town, I'm walking around Walmart, wherever. 30 minutes a day. Remember, we said that was our recommended 30 minutes a day exercise, moderate activity. They may not be able to do 30 minutes at a time. You know, we're talking about lots of different physical levels of fitness with these patients, and most of them maybe not even be able to tolerate a 30-minute walk. So we'll have to start with where they're at and work their way up to condition them and to help them get to their best level of physical health. So for somebody, it may be, okay, we're going to walk to the bathroom, to go to the bathroom instead of using a bedside commode. Or, you know, we're going to walk from our bedroom to the kitchen door. Or we're going to increase that from the door to the mailbox. And then we can eventually increase that. So, you know, if you give somebody an unrealistic expectation of you need to walk 30 minutes a day, and honey, I can't even get out of my chair and walk to the front door, that I'm not going to listen to a word you say, because I already have ruled that out as that's not going to happen for me. So we need to try to set a plan, a realistic plan for what's going to work with our patients, because yes, we have these guidelines, but it may not fit right where they're at. So we have to modify that for this patient. And come up with a plan that's going to work for them. And then we can gradually increase, because, you know, they're going to increase their stamina, their muscle strength, and their conditioning as they go, if they're able to. And then some other risk factors are diabetes, because we talked about how this kind of goes hand in hand. So having control over the blood glucose levels for those who are diabetic will help with the treatment of hypertension, because when we have really high blood sugar levels, that does also damage our vessels, our arteries. So control of our glycemic glucose levels is important, modifiable risk factor as well. So treatment hypertensions, we talked about the lifestyle changes. We're going to talk about different classes of antihypertensive medications now. So let's talk about diuretics. I know if you guys have passed meds with me that I'm kind of a stickler on you knowing these medication classes and how they work. So diuretic is used in conjunction with other types of medications to control hypertension. And diuretics decrease fluid volume and sodium retention. So this helps us get rid of excess water. Remember, if we said we have too much fluid, that's more resistance that we have to push against. So if we get rid of some of that fluid, that's going to help the heart pump better, because now we don't have all that fluid volume and we have to continually try to pump around the body. That takes a lot of pressure to pump around. So there's different types of diuretics. We have thiazide and thiazide-like diuretics, and these increase urine output by promoting sodium, chloride, and water excretion. These thiazide diuretics do cause loss of potassium, and so we need to monitor for hypokalemia, which we talked about. So you guys should know those signs and symptoms for hypokalemia. And then we have loop diuretics, which is the ones that you're probably pretty used to seeing. This is like Lasix. Lasix is a loop diuretic. This is also potassium wasting, so it's going to cause that loss of potassium. So we will need to educate our patients on those signs and symptoms. Obviously, side effects of diuretics are going to be frequent urination, right? Because that's what we're doing. We're helping the kidneys get that water out of the body and into the potty. So we want to let them know, okay, hey, you're going to take this and then you're going to pee for several hours afterwards. So should your patient take their diuretic right before they go to bed? Probably not. they're probably not going to be compliant with it because they're going to say, well, that I was up all night with that and I can't take that medication. I've heard that so many times. And we're like, okay, take it during the day. Take it first thing in the morning when you wake up. And it was a simple education that somebody could have told that patient when they first got that medication, don't take it at night. So simple, guys, but we really do need to go over this education with our patients, so that we're really, really quick to label people as non-compliant. Well, really, realistically, would I take a pill that made me pee all night? No, I would not. So it's just what's realistic, for somebody's lifestyle, which is more important for me. Sleep, absolutely. And then we have potassium sparing, like aldactone or spiractolone. So this is actually going to keep the potassium in. And you want to be careful in somebody who's taking an ACE inhibitor or an ARB with these. And we're going to talk about those in just a minute, because those hold on to potassium as well. So this is going to double the risk of hyperkalemia for a patient. So we typically will not have a patient on a potassium sparing diuretic and an ACE inhibitor. But if you see that, we need to be really cautious and suspicious of hyperkalemia. Beta blockers. So I know we passed some beta blockers in clinicals, and I've talked to a few of you about this, but for those who haven't passed meds with me yet, we have beta blockers. These reduce myocardial oxygen consumption. That's a big fancy word for how much oxygen the heart tissue needs to survive, right? So if we decrease the amount of oxygen that it needs, then this is going to help with the heart rate and the blood pressure and the contractility. So reduces myocardial oxygen consumption by blocking beta androgenic sympathetic stimulation to the heart. So it's a beta blocker. That's a hormone that it blocks stimulation to the heart, and this reduces the heart rate. So it's going to slow your heart rate down. It's going to decrease the blood pressure, and it's going to reduce the contractility, which basically means it's going to make the force of the contraction reduced. So this helps with myocardial oxygen demand. Okay. We have two different types of beta blockers. We have a beta 1, which is heart selective. So that works on cardiac. These would be like metoprolol and atenolol. And then we have non-selective, which blocks beta 1 and beta 2. So we have beta 1 that works on the heart, beta 2 that affects the lungs. And so the one that's non-selective will block both betas, heart and lung beta. And those are propranolol, labetalol, carvedilol. And we want to be very careful with administering a non-selective beta blocker to someone who has asthma or chronic lung disease, because if we block the beta 2 in the lungs, this can cause bronchospasms. So we can basically shut off their airway because we're blocking the beta 2 that has to do with the lungs. So just use those cautiously. Would never prescribe that to anybody with a chronic lung disease. We would pick a selective beta 1 beta blocker for anybody if they have that chronic lung disease. Okay. So with beta blockers, before we administer, we're going to make sure we check for bradycardia. So we're going to take a pulse. We're going to check for hypotension. So we're going to take a blood pressure. We would hold it if our systolic is less than 100 or our pulse is less than 50. And remember, our beta blockers end in LOL. So I named a few of them, but metoprolol, atenolol, propranolol, labetalol, carvedilol. So if you see these meds, and that's why I tell you on your med cards, I really want you to learn the class, because if I see propranolol, I see that it ends in LOL, and I know that's a beta blocker. And I have learned about beta blockers they're all the same, right? So, or basically they're pretty much all the same. You've got your selective 1 and 2s, but I know about that class. So I know that this is an antihypertensive medication, and that it's going to reduce the heart rate, it's going to reduce hypertension. And so I know about that class of drugs in general, without having to look it up, right? So these are just little tips and tricks that I'm trying to give you guys to help you with pharmacology. So that's beta blockers, okay? So we also want to teach our patients to change position slowly, because this can cause orthostatic hypotension if they stand up really quickly. So we want to teach that as well. Calcium channel blockers, these end in pine. So we have like amlodipine, and then you also have diltiazem as well. So not all of them end in pine, but the majority of them do. So when we talked about the SA node and the AV node, so this decreases node conduction. So this decreases the conduction at which those impulses are firing to control the heart rate. So this slows the heart rate and decreases the strength of contraction. So that decreases the workload of the heart. They also dilate smooth muscle of the coronary arteries. Okay, so calcium channel blockers are this awesome little drug. So they can cause bradycardia, constipation, and headache are your most common side effects. And we don't want to administer these with grapefruit juice. Okay, so this is the kind of information that I want you guys to know when you do your drug cards. I expect to see all of this on your drug cards. These are the type of information that I want to see. ACE inhibitors or angiotensin converting enzymes. These, like lisinopril, these will all end in pril, or the majority of them end in pril. This is usually our first line treatment, and this blocks conversion of angiotensin 1 to angiotensin 2, and that promotes vasodilation. So that takes our veins and makes them bigger, right? So if we take our veins and we make them bigger, then we have more room for our blood to flow through the vessel. So we're decreasing that peripheral vascular resistance, correct? And it also helps the kidneys excrete sodium. This causes aldosterone levels to decrease, which I know we haven't gotten into endocrine yet, but aldosterone plays a major role in this as well. Aldosterone, when it's decreased, it causes the kidneys to keep potassium and excrete sodium. And remember we said whenever sodium goes, water goes. So if we're getting rid of sodium, we're getting rid of water. Okay, so just like when we're treating with a diuretic, diuretics get rid of water. This is helping us get rid of water. But, and so then it reduces the pressure with which we're having to push the blood against. So it's lowering our blood pressure. But again, we need to take our blood pressure, take our pulse before we administer these. And with an ACE inhibitor, our patients can have what's called an ACE cough. And it's not super common, but it can happen. It's very just annoying to the patient and just, not a pleasant side effect. They can just have a dry cough that doesn't go away. And the only way to make the cough go away is to discontinue the medication. So some people can't tolerate an ACE. And so, like we said, if this is a first line treatment, but they develop that ACE cough and they're just not able to tolerate it because they develop that ACE cough, then they'll put them, I went too far. They'll put them on an ARB. So an ARB is the angiotensin 2 receptor blocker, and it works very similar to ACE. It's going to decrease the aldosterone, keep the potassium, excrete the sodium, get rid of sodium, get rid of fluid, right? And this is prescribed as an alternative to the ACE inhibitor, but we won't have the dry cough. But I think we see better blood pressure control with an ACE, and so that's why they want to prescribe that first. But that is, if a patient can't tolerate it, I wouldn't want to have a dry cough for the rest of my life, all day, every day. That'd be terrible. So we'd have to find an alternative therapy for them. So these are some of the different classes of the medications that I want you guys to know. And you should have one of each of these on your list on the cardiac drug cards. So I want you guys, when you're writing out the drug, I want you to tell me, and it doesn't have to be, fancy words, in your own words, how the drug works. Because I see a lot of you guys writing on your drug cards words that you don't know and you don't understand, and that doesn't help you study. So if you're just, going through and just copying and pasting, or you're just writing words down from your drug book that you have no idea what the words even mean, it's not helping you. So you're going to have to stop, look up the terms, look it up, Google it, whatever you need to do to understand what it is that you're writing, because it really just does you no good if you're writing down a bunch of words that you don't know what it means. So when you're doing your drug cards, know those terms. If you're reading your drug book and you're like, I have no idea what this means, stop and look it up. And then write down that medical term, and then in parentheses, write what it means. Hypokalemia, low potassium. So write that out to the side in parentheses. That'll help you learn those key terms. But again, if you write on your med card, monitor for hypokalemia, and then I ask you, what are those signs and symptoms of hypokalemia we're going to monitor for, and you don't even know what that means, that's defeating the whole purpose of having you do the drug card. Okay. So that's really what I'm wanting you guys to get out of this, is I want you guys to look that up, and this is a tool to help you learn, but only is as effective as you using the tool properly, right? Okay. Some vasodilators like hydralazine, isosorbide dinitrate. These are alternatives to ACE inhibitors. They cause venous dilation. Again, we dilate the vessels, more blood flow can go through, less resistance. It lowers our preload. We have lower systemic vascular resistance. Orthostatic hypotension, again with these, so slow to rise would be your education for your patient. Digitalis, I'm going to share with you guys, I'm obviously pre-recording this, but I'm take a drink of this one. I have a really interesting video on digitalis that I'm going to share with you as well. This has a positive inotropic mechanism, which basically means the heart has an increased ability to pump stronger, and a negative chronotropic, which means it makes it beat stronger and beat slower. So it's going to slow the heart rate down. It's going to make it beat harder, more forceful contraction, and it's going to beat slower. So it beats slower and more efficiently. This is great if you have left ventricular systolic dysfunction like congestive heart failure, which we're going to talk about later, used alongside an ACE or an ARB. Again, like we've talked about before, this has some toxicity issues, so we want to monitor for dig toxicity. And there is an electrolyte balance that can precipitate dig toxicity, and that is hypokalemia. See, here's our potassium again coming up. So it's really important that you guys know hypokalemia, okay, especially when we're talking about cardio. So, and we also have to do levels of dig. So we have to draw it. It's only therapeutic in a very narrow range, which is 0.5 to 2. So we have to draw dig levels. And if the level's high, we have dig toxicity. If the level's low, well, it just is not doing us any good. So it's one of those drugs that it's a really old drug. It's been around for a really long time. But it does kind of have those, it's just a very tricky drug because we have to keep it in that narrow range, and it's very easy to either be subtherapeutic or have toxicity. So the antidote to dig is called Digibind. So that's pretty easy to remember. So if anybody has ever has dig toxicity, we would give that Digibind antidote. Signs and symptoms of dig toxicity are nausea, vomiting, and vision changes. So they can see like yellowish green halos. And we always want to check what before we give dig? Apical pulse. You guys should know that. You study that, like, for your drug test over and over again. So, or for your med check off. Aspirin. I know you guys have had a lot of patients in the hospital that are on aspirin, and I've asked you why they take it. So I hope If you've at least passed meds with me, you know why your patients are on aspirin. It's usually not just, because you stubbed your toe. So aspirin actually prevents platelet aggregation and reduces incidence of MI and death in patients with cardiovascular disease. So that's why somebody would be on an aspirin. It'd be platelet aggregation. So remember, you said the thicker our blood is, the more resistant and the more we have to push to get a thicker liquid through a small hole and then a thinner liquid through a small hole. So we want it to be thinner and we don't want the platelets to aggregate. Side effects of aspirin can be GI tract upset. So we can give it with an H2 blocker like Pepcid or a PPI like omeprazole. Usually it's given at bedtime. So complications of hypertension are atherosclerosis, which we talked about previously, but this is thickening or hardening of the arteries. It's caused by buildup of plaque. Plaque is made up of cholesterol and triglyceride. This is that LDL, that bad fat that we were talking about, and it builds up in the arteries. And hypertension can cause this. Risk factors may include high cholesterol and triglyceride levels, high blood pressure, smoking, diabetes, obesity, inactivity, and obviously a diet high in saturated fats. MI. So we're going to be at high risk for MI because we have that plaque that builds up in those arteries, and that can rupture and cause occlusion to the veins that feed the heart muscle. So if we suddenly cut off blood flow to the heart and it's dead down here, it's not going to pump anything out because it's dead. So that's not good, right? So hypertension puts you at risk for having an MI as well, and stroke, because we can have not only the plaque rupture in the vessels to the heart, you can have a rupture in the vessels in the brain, and then we have death to the brain, ischemic stroke, which we'll talk about more later, but we have that death to the brain. And then kidney damage, which we've kind of already talked about. So we have damage to those vessels in the kidneys. We can also have damage to the vessels in our eyes. So damage to the vessels behind the retina. So these are all things that are complications of hypertension. And that's why the number of deaths that are related to hypertension are so high, because hypertension has this cascade effect within the body to where just all these horrible, terrible things can happen if our hypertension is not controlled. Hypertensive urgency is when our blood pressure is elevated, but we don't have target organ damage. And when we say target organ damage, it's basically damage to our critical organs, so our heart, our kidneys, and our brain. So our blood pressure is high, but not to the point where we are having brain damage or kidney damage or heart damage from it. Once we get into the hypertensive emergency, we are starting to see those signs of the damage to those organs. Okay, so we might see elevated CPK and trope. We might see elevated BUN and creatinine because we have decreased blood flow to those organs and they're showing signs of damage, right? Systolic blood pressure greater than 180 or a diastolic greater than 120. We have that organ damage. And so the treatment is we're going to gradual reduction of the blood pressure. We don't just slam it back down to like 100 because they can have severe complications with that. So we gradually bring the blood pressure back down in this hypertensive emergency. And we treat it with nipride, which is a vasodilator. So we're going to dilate those blood vessels. And this is given IV and obviously an intensive care unit. Okay. So what's the primary cause of hypertension? Unknown cause. The answer number 4, you were correct. So remember we said primary or essential hypertension is the least common and it is an unknown cause. And our secondary hypertension, we have those known causes, and that's the most common type of hypertension that we have, that we see. So the nurse would include which of these as modifiable risk factors in a patient teaching plan. Select all that apply. So let's do true or false here. Can I modify my age? No. Can I modify my diet? Yes. Can I modify my family history? No. Can I modify my glucose control? Absolutely. Can I modify my weight? Absolutely. So diet, glucose, and weight, right? Okay. The nurse is contributing to the plan of care for a patient with new onset hypertension who has requested information to manage her hypertension. Which of these nursing diagnoses is appropriate? Would be readiness for enhanced health literacy, because she requested information, so she's showing us that she has readiness to learn, right? Okay. The nurse evaluates the patient as understanding teaching if the patient states hypertension must be managed by which time frame? Lifelong. It's a lifelong disease. It's not going to be cured within ever. I mean, it's lifelong management. 6, 1 year, 10. It's one of those that you have it, but we can manage it. Okay. What should the nurse include in patient teaching plan to prevent falls when taking antihypertensive medications? So true, false. We should sit at the bedside when changing positions. True. Rise slowly when standing. True. If dizzy, sit down. True. Stand up quickly. No. Request assistance to stand if I have a history of falls. True. If you're in the hospital setting, most definitely. Now, you may not always have that at home, but can we say that that's true? A true statement? Yes. Okay. That's it. I'm going to get this video wrapped up and edited, and you guys can take a break. Miss McPherson's going to give you your assignments to work on, and then she'll play the second video for you. And I'll see y'all tomorrow.